Aloha, welcome back to General Pharmacology. Let's move the PowerPoint slides and get started today and start talking about actual things that pertain to pharmacology. So the pharmacology course really begins here with basic principles of pharmacology. My predecessor spent about 30 minutes covering the stuff that we're going to go over in about 2 weeks because I really think it's important for you to understand these foundations. Your understanding of the toxic interactions of medications are not going to come from you understanding the medications. Your understanding of toxic interactions through with medications, your understanding of those toxic interactions are going to occur from having an understanding of how the body processes drugs. And so that's what we're going to go over in the next 3 lectures. What do drugs do, and what does the body do to those drugs? That's the difference between dynamics and kinetics. And so most books, they'll cover dynamics first and then they'll go through kinetics. We're going to mix all that stuff up. We're going to try to cover simple stuff first and more complicated stuff later. When I send out notice to you guys, there's a little Pharmapedia. The YouTube channel has a Pharmapedia place with basic principles of pharmacology, and each of those concepts is broken down into individual lectures. And so from here through 1.5, there's a place where you can find individual concepts broken down all by themselves in their little videos. They're little unique videos instead of being a 1.5 hour long glob. And so I would urge you to take the time to learn these principles, no matter how abstract or seemingly unrelated to clinical medicine they may be. There is a very good reason that I belabor all of these points. And so that being said, let's get started. Think about pharmacology like locks and keys. You guys know what locks and keys are. And if you think about it, there's locks and keys everywhere. There's all sorts of locks and keys. And if you think about every kind of lock and key there is on this planet, you'll realize that the interaction between drugs and receptors in the body is even far more complicated than that. And so we can think of a drug as being like a key that interacts with a certain receptor like a lock. And notice that this key is cut and shaped and fit in such a way that it only fits in this receptor. It doesn't really fit anywhere else. This key is matched for this lock. And we will talk about that when we're talking about drugs that interact with specific receptors. Well, once that drug interacts with the receptor, a change in regulatory function occurs, just like a lock and a key. When that key interacts with that lock, there's some kind of change in regulation, opening the chain so we can get into campus is certainly a form of regulation. Using the key to open the door is certainly a form of regulation. And when the receptor only changes regulatory function when it interacts with the drug, this is a key feature of pharmacology and regulation in biologic systems. So pharmacology is like keys and locks. Right? When we talk about drugs interacting with receptors, it's just going to be like keys and locks. And the near entirety of time that I use this cartoon, it's going to be a membrane-bound protein that is our receptor that interacts with some kind of extracellular chemical signal that causes a change of regulatory function inside of the cell. So this is what we're going to see the near entirety of time that we talk about pharmacology. Sure, we can have this occur on the extracellular level. We can have this occur with free proteins intracellularly. But again, most of what we talk about is going to be changing something inside of the cell based on what's going on outside of the cell. So here, a drug activates a receptor that causes some chemical reaction to occur inside of the cell. Let's go back and see that again. The receptor here is not active, so it's not having any kind of chemical process go on inside of the cell. And then some kind of chemical signal, a drug, a hormone, a ligand, interacts with that receptor, activates that receptor, activates the enzyme to cause a chemical reaction to occur inside of the cell, and so then the buildup of this chemical causes some kind of regulatory change inside of the cell. And we'll see this in pharmacology over and over. There are all sorts of great definitions out there. This is the definition that I've always used. Pharmacology is the study of substances that interact with living systems through chemical processes. This is very important. That's why we talk about chemistry. This doesn't occur by magic. Pharmacology interacts with living systems through chemistry. That's the point that we're trying to make here, especially by binding to regulatory molecules like proteins and activating or inhibiting normal body processes. So think about it. When you want the lights to come on in a room, you don't have to generate the light using electron tunneling. You don't have to put the light bulbs in and do all the construction. You don't have to do all that work. To make the lights go on, all we have to do is go in and flick a little tiny switch with our little tiny pinky, and all sorts of incredible things occur. And the same thing happens in pharmacology. When we use a drug to affect a living system, what we're doing near entirety of time is affecting normal body processes. And so we're trying to change already existing systems in the body and tilt them in a direction that leads us to better health. That's why we're trying to use medications to take care of people with problems, just to make them better. And that's what this course is about. It's not about memorizing long lists of medication or whatever the drug company's latest products are. Why do I not mention new drugs? Because this is not an advertising campaign. And a lot of the new drugs that come on, they come off the market very quickly too. Many of the drugs do. So I try not to cover too many new drugs. Plus, you guys get to research that on your own. If you do all the work you're supposed to do in here, you might actually find yourself memorizing long lists of medication. Something I'll make the point right now is, like, when we talk about beta blockers, there's lots and lots of beta blockers out there, and they like to say, oh, well, they end in the words olol. Yeah, most of the time. However, if you understand the principles of just a few beta blockers, you will understand the principles of all the beta blockers. There's cardioselective, there's non-cardioselective, and then there's intrinsics and pathomimetics. And that's it, even though there's these long lists of beta blockers and their properties. And so my recommendation is to understand the package insert of one drug in each class very well, and then always look stuff up. How do I know pharmacology? How do I know anything about pharmacology? I was always looking stuff up. My pharmacology class in medical school was terrible. It was taught by a research PhD who was a super nice guy, but he said, you know, I don't know how I ended up teaching pharmacology, but he didn't think he had a very good course, and so we had to struggle and read and work together and collaborate to walk away with pharmacology knowledge, and maybe sometimes I think that would be better. But that's not what we've chosen here. So what I can tell you is, if you go to the clinical, there is a place where I have clinical discussions in the folder. If you look at those questions, you're going to see long lists of medications, and if you just continue to look over them, look them up. Every time you see a drug on TV, look it up. Every time you see a patient who's on a medication, look it up. Every time you administer a medication, look it up. Every time a pilot takes off and lands at an airport, he opens a book, she opens a book, and they look at a diagram of the airport. I don't care if the pilot has landed on that airport a million, billion, trillion times. We're going to open up the book and go through a checklist. Before we take the airplane off, before we land the airplane, we go through this checklist. And I would recommend the same thing. Every time I prescribe medications, had medications as part of their treatment plan, and I can assure you that is plenty of people, I would sit down and I would look up every medication in a guide, and you do that long enough, you're going to find out you have memorized long lists of medications or drugs. But the beginning of your career is not where the memorization occurs, okay? So you can do that if you want, but that's not what this course is about. This course is about this right here. I want you to see the beauty, the miracle, the complexity of living regulatory systems. People like me are going to sit up in the postage stamp and try to make all this as ridiculously simple as possible. Why? So you can have a clinical understanding of it. But what I want you to see the opposite side of is everything is far more complex and detailed and unbelievable in reality. All right, so just because we try to simplify things to make things easier in the clinical setting doesn't mean reality is simple. Reality is very complex. But to me, living regulatory systems are very, very beautiful. And their presence on this planet is quite simply a miracle to me. And that's why I like to talk about it and read about it. That's why I have the greatest job on earth. I don't like this word right here, drug. One thing to keep in mind, and we're going to talk about this with terminology. Maybe someday I'll do terminology first. What words mean really has to do with their context, and where they're being used. How we use the word drug in a pharmacology class is completely different than how they use the word drug on TV or social media or any kind of media. All right. So in pharmacology class, a drug is any substance that interacts with a molecule or protein that plays a regulatory role in living systems. And the first thing you think about is gray areas like, well, glucose and water and nutrition. And one thing I want to tell you, just stay out of the gray areas in this course. Stay in the black and white parts before we start digging in the gray areas. All right, so a drug is just quite simply something that interacts with a molecule that plays a role in living systems. This is the word I like to use in the clinical setting, a medication. Why? Because a medication is a drug intended for a therapeutic benefit. We use medications to make people better. Sometimes that is not what happens. That's why we study pharmacology, so we can optimize the probability of a medication having a therapeutic benefit. All right. So that's why we study these things. But I want you to know the difference between a drug, which is any substance, and a medication, which is a drug intended for a therapeutic benefit. I would be very, very disciplined about making sure that this is the word you use in the clinical setting, not that, because this has all sorts of bad connotations in social media. You talk about people who use drugs and all that, and so then drug just has this negative stigma in people's minds. That's why we use the word medication. Medication is intended for therapeutic benefit. Well, just like keys, drugs have to be specific. Drugs have to be specific size, shape to interact with a given receptor, and those interactions are not only physical but chemical as well. A receptor is a specific molecule, usually a protein, that interacts with a specific chemical that then causes a change in the specific molecule, causing a change in regulatory function. A receptor is like a lock that when it interacts with its specific key, when it interacts with its specific ligand, when it interacts with a specific drug, then there's some kind of chemical change that occurs, regulatory change that occurs. It is the receptors that are responsible for the selectivity of drug action. What does that mean? Well, it is obvious when you talk about locks and keys. Look, think about your car key. What does your car key do? Well, what your car key does depends on the lock that you put it in, depends on the receptor that that key interacts with. If you put the key in the trunk, it opens the trunk. If you put the key in the door, it opens the door. If you put it in the glove box, it opens the glove box. If you put it in the ignition, it starts the car. So it's not the key that decides what the key does. It's the receptor, it's the lock that determines what the key does. And the same thing with medications. It's not medications that determine what happens. It's the receptor that decides what happens. And so if the receptor is in the central nervous system, that drug, when it affects the receptor in the nervous system, will affect the central nervous system. And so it's the receptors that are responsible for the selectivity of drug action, just like your car. If you put your key, it depends on where you put the key, determines what the car does. And I'm sure I'll cut that out when I get to the editor. All right, so even though this is a general pharmacology class that's supposed to cover all sorts of science and biochemistry, secretly this is a medical pharmacology class. Medical pharmacology is the science of substances to use to prevent, diagnose, and treat disease, to make people feel better. Pathos means suffering. Pathology is anything that causes suffering. And pharmacology is one of the things that we can use to eliminate suffering. If we have a good knowledge of it and use it properly, then we have a much higher statistical probability of having a great outcome using those substances. So again, a medication is a drug intended for a therapeutic benefit. All right, well, toxicology is a branch of pharmacology that's going to study harmful effects of chemicals on living systems. And we will study toxins when we talk about toxicology. Something I want you to know in a formal pharmacology class is toxins are of biologic origin. They are synthesized by plants and animals. So when we talk about toxins in the physiologic setting, when we talk about toxins in a pharmacology setting, they're poisons of biologic origin. Why? Because those are the first poisons that we knew about when we started studying pharmacology, because sometimes to understand physiology we have to break things to know what they do. And so the original toxins weren't that we used to study for pharmacology were synthesized by plants and animals. Poisons will be drugs that have almost exclusively harmful effects. I don't really like this definition. We'll talk about this when we get to therapeutic window at the end of this lecture. And so drugs or poisons floats around in some of the pharmacology courses. If you're going to be a clinician that make people better, you don't want to talk that way. You want to use words medications to describe drugs that have beneficial effects. All right, well, there is this thing called endogenous, inside of genus, as in Genesis, as in to form from in the beginning. And then there's exogenous, exo, outside of the body, genus, as in Genesis, to form from the beginning. Exo means substances made outside of the body. Endogenous means substances made inside of the body. And so we will take something very simple like epinephrine. And your body uses epinephrine for all sorts of reasons that we'll talk about. And so when your body makes epinephrine and uses epinephrine, that's called endogenous epinephrine, all right? However, we can make exactly the same substance in a factory, and we can give that epinephrine to the body, and the body won't know the difference between the two epinephrines. However, if it's manufactured outside of the body, we'll call it exogenous. And so when you talk about endogenous epinephrine, that's the epinephrine that's made by the body. When you talk about exogenous epinephrine, that's the epinephrine that was made in a factory before it was injected into our patient. So in a formal pharmacology class, hormones are just quite simply endogenous drugs. They're chemical signals that the body uses. When you watch YouTube land and TikTok, hormones means a completely different set of things that have to do with behavior and androgynous things. However, in a pharmacology course, hormones are just quite simply any kind of endogenous drug. The word xenobiotic never came out of my mouth until I started sitting in this chair and talking to one of those two cameras back there. Xeno, meaning from a different species, biotic, biologicals, they are just quite simply exogenous drugs. I just throw that in there because people throw that word around in different ways. This is what I really want you to know. If you're going to learn anything today, learn the difference between dynamics and kinetics. If you know the difference between dynamics and kinetics, then you'll realize that the pharmacology descriptions are divided into dynamics and kinetics. And then when you meet the drug reps and you talk to other people who seem to know pharmacology, they will interchange the word dynamic and kinetic. And that's fine when you get out of here, but for this course, you need to know the difference. And so dynamics are just quite simply what the drug does to the body. Kinetics is what the body does to the drug. So here's dynamics. By the way, you're not going to need to know any specifics about drug classes until we get into the Section 2 material. So while I'm in Section 1 and I bring up specific medications, you really don't need to know dynamics and kinetics until we start getting to Section 2. All right, so here's an example of dynamics. Propranolol is a beta blocker. Beta adrenergic antagonist is the long way of saying beta blocker. It lowers blood pressure and heart rate. That's the most simple way of describing the dynamics of propranolol, the pharmacodynamics. It lowers blood pressure by blocking beta receptors. That's the action of the drug on the body. Its dynamics. Its kinetics are what the body does to the drug. Propranolol is broken down by the liver, made into water-soluble substances, so they can be eliminated by the kidneys. That is the kinetics of the propranolol. Here we're talking about the elimination kinetics. And so please know the difference between the dynamics, what drug does to the body, and kinetics, what the body does to the drug. It's hard to think about at first, but I want you guys to look at this abstract stuff more than one time, get a good handle on it before we move too quickly forward. This is a very important concept in pharmacology, something called the agonist. The agonist activates a receptor. Doesn't matter what that receptor does. If that receptor is activated, then the thing that activated it is an agonist, okay? And so an agonist activates the receptor by binding to it. All right, so here's my phospholipid bilayer with a membrane-bound receptor, and here at the bottom is some chemical that's probably going to change when the receptor comes in contact with its specific agonist. And so here the agonist has come in contact with the receptor, and now the receptor is activated, causing a chemical reaction inside of the cell. I wanted to point this out, that the near entirety of time we talk about this sort of interaction, if we take the agonist away, then the receptor is deactivated. And that really happens the near entirety of time. That makes sense. When we turn the light switch on, we don't want it to be permanently on. When we open the door, we don't want it to be permanently unlocked forever. All right? And so the near entirety of time, when the agonist binds to the receptor, it activates the receptor. And when the agonist leaves the receptor, it deactivates the receptor. Right? That's what happens in the entirety of time. I did see a board question that I thought was confusing, so I threw in the slide. Sometimes we'll talk about agonists that activate a receptor, and then they permanently activate it throughout the life of the receptor. And it does that through covalent change. Here the agonist has caused a covalent change on the receptor that has permanently activated the receptor throughout the life of the receptor until that cell undergoes apoptosis and is recycled like your cells regularly do. And so take aspirin. You'll read about aspirin preventing heart attacks. You might see it on TV. Oh, aspirin prevents heart attacks. And what aspirin does, you take an aspirin, it goes into your body, it swirls around for 15 minutes or an hour, depending on which metabolite you're chasing around. But the aspirin permanently changes the platelet throughout the life of a platelet by causing the covalent change on the platelet. And so in very rare circumstances, we will talk about a situation where the agonist permanently activates the receptor. But that's interesting to talk about when we talk about aspirin and board questions. The near entirety of time, I want you to remember this. Agonist binding to receptor activates the receptor. Agonist moving away from the receptor deactivates the receptor. All right, like normal locks and keys. But there are some keys out there that can permanently activate the lock. All right, so let's talk about an antagonist. All right, the word pharmacologic just means it's binding to the receptor. Antagonist means it prevents activation of the receptor. All right, and there's going to be two types of antagonists we're going to talk about. All right, so here's the competitive antagonist, and it is bound to the agonist binding site. That's like having a key that goes in the keyhole, but it's the wrong key. I do this all the time. I have two car keys. They look exactly alike, and I'm always sticking the wrong key in the ignition, in the starter. And, you know, that's the same thing here. We've put something in the keyhole, but it doesn't activate the receptor, so it's a competitive antagonist. Why is it competitive? Because it's competing with agonist at the binding site. That's where agonist would bind, and it would, other than there's competitive antagonist in the way. And if we add enough agonist, we can push that competitive antagonist out of the way. So competitive antagonist is a pharmacologic antagonist. It's going to bind to the receptor, but it's competing with the agonist, so it's binding at the agonist's binding site. That's what a competitive antagonist is. So the non-competitive antagonist is going to bind somewhere else. So that's like a lock with two keys. All right, so here's my non-competitive antagonist, and it is bound to the receptor at some place that's not the agonist binding site. So when the agonist comes and binds the receptor, well, the receptor cannot be fully activated because non-competitive antagonist is preventing its activation. This happens all the time in the body. This is normal body processes where the receptor will have several sites, several places keys can go to regulate that receptor, and that's why we see non-competitive antagonism being used more and more and more. The interesting thing about non-competitive antagonists is you can add agonist all day long. It's not going to knock the competitive and non-competitive antagonist off its binding site, and that might be something that we touch on. All right, well, these are not the pharmacologic antagonists because this is not about binding to a receptor. A chemical antagonist is a drug that binds directly to the agonist and deactivates the agonist. And so here our chemical antagonist, instead of binding to the receptor, it binds the agonist. And so maybe you've heard of digoxin, and maybe if somebody's had a digoxin overdose, we can use digibind to bind to the digoxin, and the digibind is just quite simply a chemical antagonist that binds to the digoxin. Heparin is a blood thinner we'll talk about, and protamine is its chemical antagonist. It binds the heparin, deactivates the heparin. And we need to be really careful using stuff like that, but I just wanted you to know that's where the word chemical antagonist comes from. They're not competing over binding sites. The chemical antagonist is just binding directly to the agonist. And so if we deactivate an agonist by binding to it, that's chemical antagonism. Last thing we want to talk about is physiologic antagonists. Physiologic antagonists have opposite effects, but through completely different pathways, like histamine and epinephrine. They have exactly opposite effects on the body, and that's not through competing through similar pathways, the same pathways. There's histamine receptors, there are epinephrine receptors, and when histamine interacts with its histamine receptors, the effects on the body are exactly the opposite than when epinephrine interacts with its receptors. And so they're going to have opposite effects. That's why when somebody has an allergic reaction, give them a dose of epinephrine to give them a quick opposite effect of the histamine. And so we'll talk about this more when we talk about anaphylaxis in section 3.3, histamine and the autocoids. But keep in mind, histamine and epinephrine are classic physiologic antagonists. All right, again, drugs interact with receptors by means of chemical forces or bonds. That's why we talk about chemistry and chemical things at the beginning of pharmacology. And when you read a pharmacology book, they use chemical terms throughout. So drugs interact with receptors by means of chemical forces. Covalent bonds we talked about when two atoms share electrons. They're covalently bonded. If two molecules get together and start sharing electrons, they're covalently bonded. Electrostatic changes are positive charges being attracted to negative charges. Hydrogen bonding we talked about during 1.1. Lipophilic, fat-loving bonds, those are very important in pharmacology. And down in teeny tiny print are the van der Waals forces. Those are teeny tiny subatomic forces that usually get left off the list, but they are part of the interactions. That's where they are in very fine print. So if you see van der Waals, yeah, that's part of it too. But we're not going to get into any quantum mechanics in this course, hopefully. Guaranteed. All right, so let's talk about them. Covalent bonds are very strong. Well, they're usually not reversible. So when we talk about a drug making a covalent change to the receptor, you'll read the storybook about pharmacology, and they'll tell you about some drug that makes a covalent change with the receptor. Well, that change is going to be permanent until the cell undergoes apoptosis and is recycled. So those aren't reversible. The electrostatic bonds, positive and negative being attracted to each other. We talked a little bit about that with acetylcholinesterase, the positively charged quaternary nitrogen being attracted to the positive charge. The positive charge being attracted to the negative charge on the receptor. That's pretty strong. That's very important too. Hydrogen bonds are important. They're pretty weak, but something that's very important if you read carefully very advanced pharmacology books, hydrophobic lipophilic bonds, which are very, very weak, very subtle. They're very important bonds. Something I want to point out right now is that when we talk about locks and keys, the lock is stiff and the key is stiff. The key doesn't change shape when it's in the lock. And in my cartoons, my keys don't change shape when they're interacting with the lock. But in reality, when a chemical signal interacts with its receptor, that receptor undergoes a conformational change. It's usually the drug that interacts with it undergoes a conformational change as well. And so you can think of our keys being more squishy, like a sponge, and flexible than being very stiff objects. And so those flexible interactions are essential with hydrophobic or lipophilic, the weak bonds. And again, there's van der Waals forces, which are very weak. They might be interesting to read about, but just slip them in there if you see them on the all of the above. All right. Affinity is how tightly the receptor binds to the drug. Now, in normal situations, think about keys and locks. When you put your key in the ignition, you twist it, it stays in place, but when it's ready for the key to come out, you want it to slide out very easily. You don't have to pull the key out. I've had locks like that where you stick the key in and you got to pull it out, kind of like some of the locks around here. However, the drugs are the same way. We don't want drugs to stick to the receptor and then be permanently stuck there. We want drugs to come off the receptor, have an effect, and then be able to come off the receptor as well, just like a key being able to go into a lock and come off a lock. And so how tightly that binding occurs, we call that affinity. And more affinity is not necessarily a good thing. So usually it's toxic things that say, oh, this has a very high affinity for these receptors. Oh, well, we better be careful. Bioavailability is very simple. Biological availability. Bioavailability describes the concentration of drug in systemic blood in relationship to the amount of drug given. All right, so let's talk about what that means. Well, this is what that means. How the drug is administered affects its bioavailability. And so how the drug is administered, we call that routes of administration. Are we giving it IV? Are we giving it by mouth? There's all sorts of other ways to give medications. And how we give those medications is going to affect bioavailability. And this is what I want you to know about bioavailability right here. When you give the drug directly into the bloodstream, then you, by definition, have 100% bioavailability. So by definition, IV drugs have 100% bioavailability the near entirety of time. There's some weird circumstances out there, but in general, what we want you to know is if a drug is given IV, it by definition has 100% bioavailability, because remember, bioavailability is the amount of drug in systemic blood in relationship to the amount of drug given. And so if the amount of blood, if we give the drug IV, then the amount of drug in the systemic blood is equal to the amount of the drug given. That means that's a 1, which is 100%. That's what I want you to know. What I also want you to know is that drugs by mouth rarely have 100% bioavailability. All right? And because of this thing called your portal blood supply. Your liver has trust issues. When we were all developing, we used to eat all sorts of horrible things off the ground, and your liver had to work very, very, very hard to process all that stuff, and it still does. And so everything that you eat has to go to the liver first for inspection, and your liver is busy trying to change all of that stuff into water-soluble stuff so you can eliminate it through the kidneys, and we will talk about that when we get to 1.5. But what I do want you to know is when you eat something, it goes into your gastrointestinal tract, it's going to go to the liver first, all right? Which brings us something to the first pass effect. Drugs that are taken by mouth and absorbed by the gastrointestinal tract are going to go to the portal blood supply and go directly to the liver, and then the liver is going to metabolize those drugs even before they enter the systemic blood supply. That's normal. We account for this when we're thinking about the kinetics of a drug. And so this is the first pass effect. When we take something by mouth, the liver will metabolize it, breaking down a lot of it before it even enters the systemic blood supply. So the bioavailability of an oral medication is rarely 100%. Bioavailability of oral medications, somewhere between 10 and 50%, depending on what drug we're talking about. And I don't expect you to think, when you're in school, you think, oh, well, I got to learn which drugs are 10% and 40% and 35% and 37.5. That is not correct. I want you to understand these concepts so that you can apply them in a more general sense. And so bioavailability of oral medications is rarely 100%. And this is the point I want you to know right here, because this is a major source of medication error made by people who don't take pharmacology classes here at UH Mountain College. All right, so IV dose and the oral dose. Many medications are out there that can be given orally and IV, and plenty of times the IV dose is the same as the PO dose. You'll see that. Oh, the dose IV is 100 milligrams. Oh, the dose PO is 100 milligrams. Great. And how often does that occur? Sometimes. However, do not assume that the IV dose is going to be the same as the oral dose. All right. So no. The IV dose is not always equal to the oral dose. And here is a great example of a not uncommon pharmacologic mistake. Beta blockers and IV beta blockers. All right, so an oral beta blocker has a bioavailability of 10%, let's say. We're going to use an oral beta blocker and it has a bioavailability of 10%. That means only 10% survives the first pass effect. All right. So we give 100 milligrams of dose of the drug, and only 10% of that's going to be bioavailable. All right. So if we give a 100 milligram dose with the 10% bioavailability, that means only 10 milligrams ends up in systemic circulation. So the equivalent IV dose would be 10 milligrams. All right. So if somebody's taking a beta blocker, that's 100 milligrams orally, the equivalent IV dose would be 10 milligrams. All right. And so if we assume, like, oh, well, they're on a beta blocker that the dose is 100 milligrams, oh, well, we'll just give an IV dose of 100 milligrams. You will have a disaster on your hands, if not lethality. So the IV and PO doses are not always going to be the same because of bioavailability, because an IV drug has 100% bioavailability. Rarely does a PO drug have 100% bioavailability. And that's why we have to look this stuff up. What is the IV dose? What is the PO dose? When I see young people at this stage in your career walk up to me with some kind of thing they've memorized, danger, danger, danger. You have to look this stuff up because when you get old like me, you start switching things around in your mind. That's why I want you to open up and look this material up. That's why the tests are open book. That's why I ask you questions with your books open so you get in the habit of looking this stuff up. Because if anybody's teaching you to memorize this stuff, they're teaching you how to make mistakes in the future. Intramuscular means into the muscle. And then it's stored in the muscle and out to the blood. And so you've been to Home Depot. Depot is a storage. You'll hear about ammunition depots if you read about wars on the other side of the world. And hopefully they stay there. A depot is a storage place. And so when we give a drug IM intramuscularly, that means it goes into the muscle and it stays in the muscle and is released slowly over time. That's the way we like to give immunizations. If we gave immunizations IV, the liver would get a hold of them eventually and break them down. So we put them in the muscle, we let them release real slowly, give your immune system time to react to this. So all sorts of medications are given IM intramuscularly. Something to keep in mind is the release rate from the muscle is just inconsistent across people, and it doesn't matter, male, female, big, small, so forth and so on. It's just very inconsistent delivery, but the consistency is not the point. What we want is just something slower than IV, and so we'll use IM intramuscularly. SQ is not the cute abbreviation for subcutaneous. Subcutaneous is SC, under the skin. And so we'll give insulin subcutaneously, like in the abdominal fat pad. We'll put the insulin in the subcutaneous tissue, and that'll be a great place to sustain release from for insulin. So that's subcutaneous. PR means by rectum. We use rectal suppositories in the case of a seizure and somebody needs a benzodiazepine. We can put Diastat, a form of Valium, in a rectus suppository because maybe we don't have time to start an IV in a patient having a seizure. There's no way we're going to put anything down their mouth. And so we can use suppositories. Another reason to use suppositories, if somebody has severe nausea and vomitings, throwing stuff up, we can use rectal suppositories, although there's newer melt-in-the-mouth stuff that works great. Pretty much outdating PR medications for nausea. Inhalation, just quite simply, it means directly to the lungs. If we inhale something and it goes to the lungs, then that is the site it's intended. We'll think about that a little bit differently if we inhale something to go to the bloodstream. And so there are some medications that will be inhaled to treat the lungs. There will be some drugs that are inhaled to then have a systemic response in the body. And so that's where tissue bioavailability comes from. Tissue bioavailability just describes the concentration of drug in target tissue in relationship to the amount of drug given. And I think a great example of tissue bioavailability, inhalers, if we're using them for asthma to treat the drugs, or to treat asthma, to treat the lungs. But another great example is something called erythromycin. We'll use it in the eyes, O-P-H-E-H, yeah, erythromycin ophthalmic. When a baby is born, there is a risk of infection in the eyes causing blindness, and so we'll put erythromycin in the eyes to prevent infection. And erythromycin would be a terrible drug for those bacteria other than the erythromycin, since it's in contact, is very effective, and we'll talk about that later. And so you'll come across the words tissue bioavailability, and that just quite simply means the target tissues in relationship to the amount of drug given. This is a really easy concept to think about. Bioavailability is more difficult. The only reason I bring these two things up is you'll hear these words thrown around. So again, bioavailability has to do with the amount of drug given, the amount of drug in the blood in relationship to the amount of drug given. Tissue bioavailability just means the amount of drug in the target tissue. I want you to know the difference between transdermal and topical, because these are commonly confused. Transdermal is intended for systemic supply, and so when you take a nicotine patch, you put it on your skin, you're not treating a rash. All right? You're putting the patch on your skin to give you a slow, consistent dose of nicotine, so hopefully you can get off the cigarettes. And so that's transdermal. People use estrogen patches. They'll put it on their skin. There's testosterone patches. They can put it on their skin, and they're not treating a rash on their skin. They're treating the body with these hormones, and so that's transdermal. It's applied to the skin, and it crosses the skin, but its intent is a systemic blood supply. That's different than topical. Topical means it's applied to the skin and the mucosa, and its action is intended locally at the site of administration. And so you'll see inhalers. You inhale, even though you think that's inside of your body, that air that goes all the way out to the alveoli, that's still the external space of the world, and you're using a medication that goes to the mucosa, and its action is intended where that drug ends up. So you'll hear inhalers referred to as topical. You'll see eye drops referred to as topical. Anytime you apply something to the body, whether outside or somewhere inside, if you apply and that medication ends up where it is intended locally, then that is considered topical. And so if we put something on our skin to treat that area of the skin, that's topical. If we put drops in our eyes to treat our eyes, that's topical. Same thing with inhalers that go in our nose. If we inhale things through nasal inhalation and the drug is intended at the site where the drug ends up, then that's considered topical. So I want you to know the difference between topical, which the drug is working locally at the site of administration, from transdermal. That means the drug is intended for systemic blood supply. Intranasal, again, whether this is topical. If it's topical, it's intended to treat the nose, but some drugs are inhaled through the nose for the purposes of systemic action. Some pain medications work that way. Some immunizations work that way as well. Intrathecal just means into the cerebrospinal fluid. We'll give methotrexate intrathecal when we have a young leukemia patient. If you're interested in spinal anesthesia, if you're interested in any kind of anesthesia, you're going to learn that outside of this course, but epi outside of the dura is another form of administration, and then there's peridural, and I just started skipping the anesthesia stuff after that. All right, let's talk about the agonist dose response curves. I talk about this because I see these on board questions. I don't think they're very good board questions, but we see these little squiggly S-shaped things, and then people start asking questions about them. And so we'll talk about agonist dose response curves. And the interaction between a drug and its receptor can be just described by a natural curve because we see natural curves everywhere. And I would suggest the reason we see natural curves everywhere is for exactly the same reason. And it's because drugs affect natural regulatory processes. Their effect is going to follow a natural curve that you can learn from doing the proof of a natural logarithm. All right, so here's a typical agonist dose response curve. And this looks like a hillside that goes to the right forever. There'll be an arrow right there telling you this goes on forever. And that agonist concentration is linear. So this is a linear axis. All right, so since we're looking at graphs, if you don't know anything about graphs, a graph should have a label. This is the agonist dose response curve. Each of the axes should be labeled. So this is the agonist effect. Down here is no effect. Up here is lots of effect. And then here's the drug concentration. You can say it's the drug dose. All right, no dose, big dose. Okay, so now we see this. All right? And when you see these curves, you'll see this right here. This response is going to increase in proportion to the dose, and eventually more drug is not going to result in more response. And so Tylenol, it works pretty good if you take one. If you take two, you get a little more effect. You don't get twice effect, but you get a little more effect. You start taking 3 and 4 and 5 and 6 Tylenol, all you're getting is toxicity and even lethality. You're not getting any more effect, and that's what we see from this. No drug, no effect. Some drug, a lot more effect. Eventually, adding more drug doesn't give you any effect. You've reached maximum effect, all right? And that's what we want you to see. No drug, no effect. Some drug, lots of effect. More drug, more effect. Wow, all right? And then we keep adding more drug after that. We've reached maximum effect, and adding more and more and more drug doesn't give us any more maximum effect. That's what we want to see from this agonist dose response curve. And this is a normal property of medications and their receptors. All right, so it gets confusing. You read one pharmacology book, their agonist dose response curves look like that. Oh, I'm sorry, here. Effect increases in proportion to dose, diminishes over time, and eventually adding more drug does not add more effect. All right, it gets confusing. You see these curves that look like that. All right. What's next here? All right, there's this thing called half of maximum effect. And notice only a small concentration of drug is needed to get half of maximum effect. And that's the EC50, the concentration of drug needed to get half of maximum effect. I don't need you to know too much about an EC50. We're going to try to move through that. This is the point I'm trying to make right here. Some of the curves look like this, and other point curves, they look like these little S-shaped things. And so we're going to start talking about these little S-shaped curves when we talk about agonist dose response curves. And it's just quite simply a logarithmic axis on the bottom, all right? Linear axis, logarithmic axis. All right, so if we change the way the axis is formed, we can make this any shape we want it to be. So depending on the logarithm, we can make it a nice S shape. And notice it doesn't go on, it doesn't really need to go on forever. It just makes this nice little S shape, all right? So instead of linear, we can make a logarithmic. I guess we'll show you really quickly what logarithmic and linear is. This is linear axis. Each space on the axis is equal to the previous. So the space is equal to 1. And so each space is equal to the previous one. Great. Now let's go to logarithmic. A logarithmic axis is like this. And this is a logarithmic 10. And so each space is basically 10 times of what the previous space was. All right. So it's a logarithm in the base 10 here. All right. So from 10 to the 0 and 10 to 1, that's basically 10. That space is 100. That space is 1,000, 10,000, and so forth. And so each space gets, each individual interval gets bigger and bigger and bigger. The difference between 10 to the first and 10 to the second is much smaller than the difference between 10 to the sixth and 10 to the seventh. All right. So then as we go across the axis, the numbers just get bigger and bigger and bigger. It doesn't have to be 10. It can be any number we want. All right. And so it's a conceptual thing. And so that's why some of the dose response curves look like this. And some of them look like that, just quite simply what the bottom axis means. And so if they draw an S shape like that, they need to label the graph, they need to label the coordinates, and they need to be sure to write logarithm on the bottom. Unfortunately, most of the people that write boards, they don't go into this detail. They just draw some S-shaped thing and then start asking you questions about it. Right? What I want you to see is notice this sweet spot on the curve where just a very small change in drug and concentration can cause a big change in agonist effect. And remember, we're activating and inhibiting normal body processes. And so like turning on the lights, we don't want that to be a big, complicated process. We want turning on and off the lights to be something that requires just very little energy. And so that's what we see from this, that only small changes in drug concentration are required to make big changes in effect. And this is how your body regulates itself so efficiently. It only has to make small changes in one to affect big changes in the other. You'll see calculus everywhere. You'll see natural curves everywhere. I see calculus everywhere, but you might see natural curves everywhere. One of the most incredible experiences of my life was taking a calculus class and going through the proof of the natural logarithm. However, something I should have spent more time in is learning to surf. I think that would have been much more valuable time than calculus. All right, so if you hang out on the beach, see all sorts of natural curves, and I'm here to tell you they all come from the same reason. All right, so now we know what the little S-shaped things are. We can talk about the difference between potent and efficacious. Efficacy just quite simply refers to the effect of a drug. The more effect the drug, the more efficacious the drug. All right. So here, yellow drug has more efficacy than the green drug because yellow has more agonist effect. See, here's the maximum effect of yellow drug. That's much more effect than the green drug. All right, so despite what the manufacturers of Tylenol will tell you, morphine is much more effective at controlling pain than Tylenol. All right, so if the agonist effect is pain control, then morphine has much more effect than Tylenol. So here the yellow drug has more efficacy because the yellow drug has more maximal effect than the green drug. All right. Well, then there's potency, and that's just quite simply the concentration of drug needed to get the same effect. And so when a drug is more potent, it really has the same effect, just does it at a smaller dose. All right, and so here is, let's say, this drug. The green drug is morphine, and the yellow drug is Dilaudid. All right, and I have it backwards. The yellow drug is morphine, and the green drug. No, wait a minute. Let me see this. Which one's more potent? I get maximum effect from this drug at a dose where I get no effect from the green drug. All right, so the yellow drug is a very strong painkiller, like Dilaudid. And the green drug is not as potent. We'll say it's morphine, all right? And so we'll take 1 milligram dose right there, all right? And if I give a 1 milligram dose of the yellow drug, I get maximum effect from the drug, kind of like Dilaudid. Dilaudid at 1 milligram, it's a pretty big dose, all right? Well, 1 milligram of morphine, it barely gets started working at 1 milligram, all right? So when you compare morphine with Dilaudid at the same dose, one drug has much more effect than the other. All right. So potency has to do with the concentration of drug, the dose of the drug required to get the same effect. All right. But efficacy is about one drug having more effect than the other. And when you got in the clinical setting, people are going to use efficacy and potency. They're going to interchange those two words like they kind of mean the same thing. But for boards in pharmacology, efficacy just quite simply means one drug has more effect than the other. And here, the yellow drug is more potent because it reaches maximum effect at a concentration that the green drug is only starting to work. You might see binary curves. The binary curve means the effect is achieved or not. So not everything fits this agonist dose response curve. Like we're going to use drugs to stop a seizure. We give a little bit of drug, the seizure's not going to be a little bit less. And we give more drug, the seizure's a little bit less. No, they're having a seizure and we're giving them drug and we're giving them drug and we're giving them drug. And then finally we stop the seizure and that's when we get maximum effect. So there's only zero effect and maximum effect and nothing in between. And we'll see that as well. Something else very interesting to study is something called quaternary dose effect curves and quantum dose effect curves, and I'll let you guys look those up on your own. All right, so again, the agonist is any drug that binds to a receptor and activates the receptor. I think we've seen this. Yes, we have. So there, my agonist is binding to the receptor. All right. All right, well, here's my competitive antagonist binding to the agonist binding site, and it prevents the agonist from binding. But I told you, if we add enough agonist, we can bump that competitive antagonist right off. All right? So there's my competitive antagonist, and if I add more and 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 more agonists, finally the agonist is going to win the competition. Competitive antagonist is not going to be able to be an antagonist anymore. And so what we're trying to show you here is that with you have a competitive antagonist, the body can overcome that. If you're using a competitive antagonist as the drug, there is a potential for the body to overcome that by making more agonist. All right? And we see that with the dose response curves. And I don't want to get too deep into this. This is kind of complex, but this is a normal agonist dose response curve drawn on a linear scale. And if we just take some antagonists, competitive antagonists, put it in the solution and do the same thing, well, notice that, right around here, the antagonist is working really well. But there comes a point where we can add enough drug to completely win the competition and reach maximum effect. And so that's the point here, is that when there's a competitive antagonist involved, agonists can be added to the point of reaching maximum effect. Non-competitive antagonists cannot be bumped off their site by the agonist. And so what it's done is the non-competitive antagonist has prevented activation of that receptor. And adding more and more agonist is not going to win the competition. That's why it's called non-competitive. You add agonist all day long, you're not going to fully activate that receptor because it's been shut down by the non-competitive antagonist. And we see a completely different set of curves when we do that. When we saw the competitive antagonist in solution, the agonist dose response curve eventually reached maximum effect. But when we use non-competitive antagonists, the agonist can't win the competition and reach maximum effect. But something very interesting is the EC50 is the same on those curves. And so if you have mathematical interests, that's a fun thing to study. But I just wanted you guys to see that the whole point was that antagonists can't overcome a non-competitive antagonist. This is what I like to talk about when we talk about little S-shaped things, something called the therapeutic window. Somewhere out there, a pharmacology curriculum begins just like this: all drugs are poisons, and something I completely disagragree with, and something I would strongly recommend that you never talk to your clinical patients that way. Imagine a nurse walking up to you and saying, oh, well, all drugs are poisons. It's not true at all. Paracelsus was somebody who studied pharmacology, and at the beginning of 1500, he started having a very scientific approach to using medicinal substances to make improvements. And this is the key here. Drugs are poisons, but the benefit depends on the dosage. And again, this is why I like to use the word medication, because we use medication at a dosage that statistically maximizes our therapeutic benefit. And so we'll draw these dose response curves again. My medication dose on the bottom is a logarithmic axis. I talk about all the people who forget to mention that, and I'm one of them. But again, my graph has a label, and each axis is properly labeled as well. All right, so here is the agonist dose response curve, and we're looking at the therapeutic effect of a drug. It doesn't matter what the effect is of that drug. If we can measure it, then we can put it on a scale, and here's the higher doses. All right? And again, when we watch this curve unfold, we'll see that no drug, no dose results in no effect. And then we'll see the sweet spot of the curve where a little more drug results in a lot more effect. And then the curve will reach maximum effect. And so, no drug, no response. Little drug, little response. Adding a little more medication, wow, we start getting a lot of therapeutic effect. And then eventually we get to the dose of the drug. We're adding more and more and more drug. Doesn't give us any more therapeutic effect. If anything, it's going to give us toxicity and even lethality. Right? So this is agonist dose response curve, a little S-shaped thing I showed you in the previous set of slides. All right, now the toxic effect of a drug fits this agonist dose response curve as well. The toxic effect is a response to a drug. And notice, no drug, no effect. And then we get to a certain dose, we start getting a lot of toxicity. And then we get to a certain point, we're not going to get any more toxicity from the drug. What we're going to get is lethality. That's what starts here. Once we get maximum toxic effect, we start risking lethality. And so notice we have two dose-response curves. We have the therapeutic effect in green. We have the toxic effect in red. And they both match that agonist dose-response curve on a logarithmic scale. All right, so look at these parts of the curves right here. Look, it's subclinical effect. We don't add much drug, we're not going to get any effect. All right, so no drug, no effect. That's what we see on that side of the scale. All right. Well, from that point in the dose, as we add dose between the point where we have between the dose of no effect and the dose of maximum effect, is this our point right here? And notice we've gotten maximum effect with no toxicity. Right? So notice we've gotten therapeutic effect without toxic effect. That's our ideal therapeutic window right there. All right, well, we add a drug after that. We're not getting any more therapeutic effect. All we're getting is more toxic effect. We already have the therapeutic effect. And we add drug after that. What do we get? We get toxic effect. All right. So in these doses, it makes sense. With very small doses, we don't get any therapeutic effect, and we don't get any measurable toxic effect. And then very large doses, wow, we can get toxic effect. And right in between that is the therapeutic effect without toxicity. That is what we would call our therapeutic window. What is between the dose of no effect and the dose of toxicity? And that's our therapeutic window. And notice we're able to dose this medication to achieve maximum effect with zero toxicity. Wow, if every drug would be that way, then what a wonderful world it would be to get maximum therapeutic effect from a medication with no toxicity. And that is an ideal therapeutic window. All right? It's an ideal therapeutic window of a very safe medication. We can dose this with no toxicity whatsoever. That's a safe medication. Unfortunately, the near entirety of drugs that we're going to deal with in this course are not considered safe medications because they have a narrower therapeutic window. Right? So here our therapeutic window is smaller. And so in this case, our dose of medication, we can reach pretty good effect with the dose of medication right in here, but we start adding more medication, we start getting more toxicity. And so the narrower, smaller the therapeutic window, the more difficult it is to achieve a therapeutic dose without toxicity. And so the narrower the therapeutic window, the more dangerous the medication is. And so notice here between these dosages, we can get some effect with no toxicity. But as we dose the drug for more therapeutic effect, what do we start getting? We start seeing signs of toxicity. And so we have to be careful about those medications and be on the lookout for toxicity of the medication because we're trying to achieve maximum therapeutic effect with minimum toxicity. Right? Some drugs, the therapeutic window is essentially closed, and those are toxic medications. And we'll talk about alkylating agents, cancer chemotherapeutic agents, and any kind of therapeutic benefit whatsoever involves toxicity. And so the therapeutic window is essentially closed. That any therapeutic effect that we're going to get involves toxicity. And so this is how we define toxic things. This is how we define things that are poisons, that we don't really get a therapeutic effect before we get lethal effect. And so when we talk about all those things, we want to talk about these things in the concept of a therapeutic window. And so some of the cancer chemotherapeutic agents that we use that are cytotoxic, they create toxicity at any dose. And so any therapeutic dose is going to result in toxicity. And so that's where the words toxic medication come from. And so this is how I divide safe and dangerous and toxic medications, quite simply based on their therapeutic window. When you read other people talk about the therapeutic window, they're going to use a lot of mathematics. They're going to use LD50s and TD50s. I think we're getting ready to talk about that. But I wanted you to see my version of therapeutic window and how I define ideal therapeutic windows, safe medications, dangerous medications, and toxic medications. All right, let's go through some 50 things before we leave this lecture. The EC50 is the concentration of drug required to achieve half of the maximum expected response. Something very similar is the ED50. The ED50 is the dose of the drug required to achieve the expected response in half the subjects given the drug. And I'm not going to push the difference there too much. I just want you to know that there is a fine difference between EC50 and ED50. And you look at the books and they'll switch those back and forth like someone else I know. But they are something different. All right, something related to the ED50 is the TD50. It's the dose of the drug required to achieve toxicity in half the subjects given the drug. And this is where I get emails saying, why are you giving drugs to people and trying to make them toxic? I'm like, I'm not. This is just a way of describing the toxic dose of the drug. And the subjects we're talking about are usually things like mice, because mice and rats and their response to medications and their immune systems is all too similar to our own for comfort. And so the TD50 is just quite simply the drug that would cause toxicity in half the subjects, because causing toxicity in all the subjects, that's a very unreliable number, because getting all the subjects to respond in the same way is very unreliable. But you can expect half of the subjects to respond in a predictable manner, and that's why we use the 50. And so what I'm telling you is, if you have a patient in the emergency room and they have consumed the TD50 of the drug, then we know there's a 50% probability that they will have toxicity from that drug. And the reason we talk about that is the LD50. The LD50 is the dose of the drug required to be lethal in half of the subjects given that drug. And no, we're not trying to cause lethality. What we're doing is trying to describe the lethal dose of a medication. And so if somebody takes the lethal dose of, if somebody takes the LD50 of a drug, which is usually described in milligrams per kilogram of body weight, if they take the LD50 of a drug, they have a 50% chance of having lethal consequences for that if it is not treated. And so that's what the LD50 tells us. It just tells us the toxic dose of the drug, or the lethal dose of the drug, but not in everybody, in half of the people. So if you give this dose, if a person consumes that dose, there is a 50% chance of lethality. And even drugs like caffeine have an LD50. I was reading about somebody who got caffeine in a powder, and they could spoon it into their power drinks and drink it before they go work out like an animal. And they didn't read the directions carefully, and they gave themselves the LD50 of the drug, and they died from a caffeine overdose, which was supposed to be a nutritional supplement to improve their health. And that's a different business that we will talk about in the upcoming lectures. All right, well, that's more than enough introduction to pharmacology. When we come back, we will study more basic principles in pharmacology. We'll cover 1.4, basic principles in pharmacology, number 2. Until then, aloha.